Hello, I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM and AMCHP, welcome to our webinar today. NIHCM Foundation is a nonprofit, nonpartisan organization dedicated to improving the health of Americans by spurring workable and creative solutions to pressing healthcare problems. The Association of Maternal and Child Health Programs is a national resource, partner, and advocate for state public health leaders working to improve the health of women, children, and families, including those with special health care needs. We're pleased to partner together today to convene an excellent panel of experts to explore ways to connect women to dental coverage and care during pregnancy. Before we hear from our speakers, I want to thank Emily Eckert from AMCHP and the NIHCM staff who helped convene this event today, including Kate Ellis, Katy McDonald, Carolyn Myers, and Kirsten Wade. We're also grateful for the funding support for this event from the Health Resources and Services Administration, Maternal and Child Health Bureau, for this project under the grant program, the Alliance for Innovation on Maternal and Child Health, Expanding Access to Care for Maternal and Child Health Populations. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website, www.nihcm.org. We also invite you to live tweet during the webinar today using the hashtag oral health. By the end of today's webinar, we hope all of our participants will be able to identify access barriers for women as they attempt to receive dental care while pregnant, replicate strategies in other states to increase the number of women receiving dental care during pregnancy, and coordinate with public and private health plans to improve dental health benefits and service delivery for pregnant women. At this time, I'm pleased to introduce our first speaker, Katrina Holt. She's Director of the National Maternal and Child Oral Health Resource Center at Georgetown University. We're so grateful she's with us today to share an overview of oral health care access for pregnant women and an update on the impact of the ACA on options during pregnancy through Medicaid. Katrina?
Thank you, Catherine, and good afternoon. This is Katrina Holt. I'd like to start by thanking the Association of Maternal and Child Health Programs and the National Institute for Healthcare Management Foundation for hosting the webinar. In my presentation, I'm going to provide an overview of access to oral health care for pregnant women, share some barriers and strategies for accessing care, and highlight a few resources to support your efforts to improve access to oral health care. If you're not familiar with the National Maternal and Child Oral Health Resource Center, the project is funded by the Maternal and Child Health Bureau to support professionals, in particular those who are working in or with state maternal and child health programs. The Resource Center gathers, develops, and shares information materials to promote sustainable oral health services for the MCH population, especially for families with low incomes or with limited access to high-quality oral health services. Pregnancy is a unique period during a woman's life and is characterized by complex physiological changes which may adversely affect oral health. At the same time, oral health is key to overall health and well-being. The U.S. Surgeon General, the World Health Organization, and many other experts have all recognized that oral health is an integral part of health for pregnant women. And we know that preventive, diagnostic, and restorative dental treatment is safe throughout pregnancy, and it's effective in improving and maintaining oral health. In 2011, the Health Resources and Services Administration's Maternal and Child Health Bureau, in collaboration with the American College of Obstetrics and Gynecologists and the American Dental Association, and with the assistance from the Resource Center, convened an expert work group. The result of this work group was the publication, Oral Health Care During Pregnancy, a National Consensus Statement. The consensus statement presents guidance on oral health care for both prenatal care health professionals and oral health professionals. It can also be used to advance national and state policies to match professional guidance. Access to oral health care for pregnant women continues to be a challenge in the United States and is impacted by a number of factors. Some pregnant women and health professionals don't understand that oral health care is an important component of a healthy pregnancy. In addition, some pregnant women believe that poor oral health care during pregnancy is normal, and some with obvious signs of oral disease unfortunately don't seek or receive care. According to a recent survey that was conducted by the Children's Dental Health Project, 63% of pregnant women didn't know that it was safe to get their teeth cleaned during pregnancy or thought it was unsafe to do so. Other barriers that impact pregnant women's access to care include a lack of dentists willing to treat pregnant women because of perceived risks during pregnancy, a difficulty finding dentists participating in Medicaid, lack of dental insurance coverage, and pregnant women's inability to pay for care. Additionally, challenges associated with finding child care and getting time off of work, lack of access of transportation, and late prenatal care entry, all of these impact pregnant women's access to care. Although there is limited information about the use of oral health care during pregnancy, some data are available for some states. From data that was collected in 2011 as part of the Pregnancy Risk Assessment Monitoring System, or PRAMS, reports indicated that 38 to 57% of women reported going to a dentist or a dental clinic. 31 to 49% had their teeth cleaned during a recent pregnancy, and 15 to 31 reported going to a dentist for a problem. Given that nearly half of all births in the United States are covered by Medicaid, it's essential for women to be able to access oral health care through Medicaid to reduce both the mother's and the child's risk for oral disease. As the largest payer for maternity care in the United States, Medicaid has a very important role to play in improving perinatal health outcomes. Dental benefits for adults enrolled in Medicaid vary across the country, with states having the flexibility to determine what benefits to provide to enrollees. Furthermore, there are no minimum requirements for dental adult coverage. Most states offer some dental benefits, but less than half, of the states provide comprehensive oral health care. MSDA's 2014 National Profile of State Medicaid and CHIP oral health programs shows that there are 9 states where pregnant women have more dental benefits than non-pregnant adults. The profile provides current and archived Medicaid data, a state comparison tool, and other resources. This helpful tool of information and materials is available online, and individuals can register as a public user. So I encourage you to use this tool to find some helpful information in your work. In addition to Medicaid providing some dental benefits for pregnant women ages 21 and over for enrollees, it's important to remember that Medicaid and the Children's Health Insurance Program serve children and adolescents up to age 21. And children and adolescents, including pregnant adolescents enrolled in Medicaid and CHIP, have coverage for dental services, including oral examination, preventive care, and also treatment. With only half of women going to the dentist during pregnancy, there's a need for practical and meaningful ways to promote access to care. This slide and the next slide provide a few strategies, such as educating the public about the importance and safety of care during pregnancy, to integrate oral health topics into prenatal care topics that can increase women's awareness of care and their ability to successfully navigate the healthcare system, and also sharing of education materials that are written at a reading level that everyone can understand and act on these recommendations. These strategies build on the idea that pregnancy provides a teachable moment when women are more motivated to adopt healthy behaviors. And health professionals and community providers can also increase access to care by helping pregnant women complete applications for insurance coverage or social services for other necessary services like transportation. They can also provide a list of dentists in the community, including those who accept Medicaid, and contact a dental office or clinic to facilitate care. Other strategies for improving access to care for pregnant women including supporting the development of state perinatal oral health guidelines to promote current standards of care, to strongly advocate for Medicaid coverage to reduce financial barriers, and to support safety net dental clinics. Many states and communities are tailoring oral health literacy campaigns and using community health workers, case managers, and program staff to educate pregnant women about their eligibility for Medicaid dental benefits and helping to link them to care. And one final strategy is that obstetricians, nurse midwives, and family physicians can promote oral health since women are more likely to see a primary care health professional than an oral health professional during pregnancy. These health professionals can provide oral health education and help connect pregnant women to sources of care. The Maternal and Child Health Bureau is also a leader in promoting oral health and overall health for pregnant women. As part of the 2015 Title V MCH block grant application, states selected 8 national performance measures based on a statewide needs assessment. 30 states and jurisdictions selected National Performance Measure 13, which is the percentage of women who have had a dental visit during pregnancy. Many states and jurisdictions that have selected this measure are building and strengthening connections for working in partnership with state programs, dental schools and dental hygiene schools, private practice, community programs, and other entities to address access to care for pregnant women. To learn more about the National Performance Measure 13A, I encourage you to visit the Resource Center's website. In addition to the Maternal and Child Health Bureau, there are other federal agencies and national organizations that can support your efforts to promote access to care for pregnant women. A few of these resources are listed on this slide. For example, CDC's Pregnancy Risk Assessment Monitoring System is a good source for state-specific data on maternal oral health experiences before and during pregnancy. In closing, I'd like to thank you for listening to the webinar today and for your efforts to improve access to care for oral health for pregnant women. If you have questions related to the topic of oral health for pregnant women or related to services for children and adolescents, please do not hesitate to contact the Resource Center. We really look forward to hearing from you. Thank you very much.
Thank you so much, Katrina, for that great overview on the topic. Katrina touched on some of the efforts in the states, and our next set of speakers are going to elaborate on some state efforts. We'll first hear from Ilise Marrazzo, who's Director of the Maternal and Child Health Bureau at the Maryland Department of Health and Mental Hygiene, and Katy Battani, who leads Maryland's Perinatal and Infant Oral Health Quality Improvement Program. And they're going to be sharing how they're partnering to improve oral health care utilization in Maryland. Ilise and Katy?
Thank you. So good afternoon, everyone, and thank you for joining us. We're doing our own slides. Sorry. So thank you, everyone, for having us speak this afternoon. We greatly appreciate it. The relationship with Title V and the Maternal and Child Health Block Grant and the Office of Oral Health goes back a number of years, really prior to my engagement or Katy's engagement with the program. Title V funding has always been part of the local health department funding within the state of Maryland, and some of our local health departments in the past have used that funding to support their oral health programs. In addition, at one point in time, the office did receive Title V funds directly to help support funds and programs. During our Title V needs assessment, which was done throughout 2014 and into 2015, it became obvious that oral health, both for pregnant women and for children and adolescents, continues to be a priority issue within the state. We, within Maternal and Child Health Bureau, always knew that. Starting back from 2009, we'd analyzed our own PRAMS data, which Katrina also referenced, to look to see whether or not pregnant women were receiving dental care. And our findings were consistent that insurance coverage tended to be the biggest issue in terms of pregnant women being allowed to access and really have available to them comprehensive oral health services. Maryland is lucky in terms that our Medicaid program does provide comprehensive dental services for pregnant women. However, those services end the day they give birth. So from one of the challenges that exists and really the growing partnership that has continued to exist between maternal and child health and oral health is to educate women prior to pregnancy as part of becoming a reproductive life plan. If you're planning to become pregnant, these are potential resources that will become available to you in terms of insurance. And then when a woman is found to be pregnant, whether in one of our Title X family planning clinics or when we're able to engage with women even in home visiting, is to continue to educate them that oral health is a covered service under Medicaid and helping them and assisting them in terms of accessing that dental care. We know that women who try to access dental care in their third trimester are less likely to complete treatment. And we know that women, and especially moms who have good oral health and value dental care, are often more likely to ensure that their children see that dentist by the age of 1. So really instilling those good habits early. Home visiting is a new partnership with us in oral health. The Maternal and Child Health Bureau has received funding since 2010 to implement evidence-based home visiting programs. And while every jurisdiction within the state of Maryland does have some level of home visiting, about 12 of them have an evidence-based home visiting program that's funded through the federal dollar. And that program is specifically the one that we're working with oral health on to educate our home visitors and to really begin to bring that oral health message home, both for our pregnant women and our new moms, to ensure that children, toddlers, other people living in the house are able to access oral health services and know the importance and provide some of that basic education. We also continue to know that our Medicaid utilization for oral health services is low and continues to be low. The biggest barrier is inability to get an appointment. Often women don't find out they're pregnant until at the end of their first trimester, making those appointments even more difficult to schedule, because often if you're a new patient, the wait time is significant. So we're really working towards that. We've continued to partner and are incredibly pleased to be part of the planning committee and group with the Perinatal and Infant Oral Health Quality Improvement Grant, as Katy likes to say, POKI, which allows us to hopefully move some more of this education forward to really begin to move women to accessing those oral health services, especially during pregnancy. So with that, I'll turn it over to you.
Thank you. Thank you, everyone. Ilise, thank you for such a great overview. As Ilise mentioned, we're partnering. Oh, yes. We're beginning to partner. We are one of 16 states throughout the country that are part of the POKI network working in this area. We just began our second year of this 4-year grant program. And so I'm going to get maybe a little bit more into the weeds, not too much into the weeds, but to provide just a quick overview of some of our POKI work. And if anyone wants to hear more or has any questions, please feel free to reach out to us. A key piece of our work is to really better understand barriers and facilitators to care during pregnancy. And so we're partnering with the University of Maryland College Park School of Public Health and the Center for Health Literacy. Dr. Alice Horowitz and her team have been conducting interviews of low-income pregnant women throughout the state in local WIC agencies. So this is really a partnership of our state WIC program, but also with numerous local WIC agencies to better understand these barriers and facilitators to oral health care during pregnancy. We're also providing surveys to these women to assess knowledge, understanding, opinions, and practices regarding the following areas: caries, etiology, and prevention, the medical and dental care received during pregnancy. If the woman has gotten into care, we are asking questions about dental provider communication with the woman. We're assessing health literacy, and we're looking at social and family supports during pregnancy. And so this research is really going to continue to inform our current work, but also to inform our work into the future. In terms of OB providers, we are partnering to begin with,
Who's touching our slide?
that's okay, I'll
Go ahead,
keep going. Okay.
Yeah.
We're really using quality improvement methodology as part of our POCI work. So we're starting small with 2 FQHCs in Maryland, one right here in Baltimore City in an urban setting, and one in a rural setting on the eastern shore of Maryland. And we're partnering with the University of Maryland Baltimore School of Dentistry to train OBGYN providers in perinatal and infant oral health. In addition to training, we're also working together in partnership to explore ways to improve utilization of oral health care for pregnant women. And one of the models that we're real excited to sort of test the efficacy of and to learn more about its impact is a model of pairing an oral health screening appointment with a prenatal appointment. And so in one of these FQHCs, this is being done. It's a 30-minute dental screening appointment prior to the first prenatal visit. And in the other FQHC, it's actually part of the nurse intake visit, which happens many weeks. Sorry, guys, we're not sure what's happening with our slides.
Who's touching that?
So in the second FQHC we're working in, the dental screening is actually part of the nurse intake appointment, which happens a few weeks prior actually to the first prenatal visit. And so the purpose of that screening is to obviously look into the woman's mouth, but to also provide an opportunity to engage in discussion with her about the importance of oral health during pregnancy for both herself and for the future infant, to talk to her about the importance of oral health care during pregnancy and to assure her that care is safe. And probably the most important piece of this is the warm handoff from the dental provider after that screening to the receptionist to get her scheduled for a comprehensive exam and preventative care throughout pregnancy. And so that is really the key piece, is that warm handoff. And that is being tested right now in our co-located FQHC facilities where dental and OB services are delivered under one roof. We're also working together to talk about how oral health is integrated into prenatal care. You know, is it part of the electronic health record? Is it part of practice? If it is, what does that look like? Is it effective? If not, why? And if a woman does not have a dental home, is the OBGYN provider providing any kind of a formal referral and resources to her and that warm handoff and any follow-up to ensure that she got into care. Another key thing that we'll be doing here in the state is developing and disseminating state perinatal and infant oral health guidelines. That's okay. And Katrina mentioned that as a key piece, and we're beginning to work on that, and that will be disseminated to all dental providers and OB providers throughout the state. Okay, Ilise mentioned home visiting. We're really excited about this because this is a new partnership and certainly something that we feel can really make an impact in getting women into care. So we just completed a statewide presentation at a home visiting conference, over 150 home visitors. And now we're going to start working a little bit more closely with a few Healthy Family America programs to provide a little bit more in-depth training, but also to work together to discuss integration methods. How can oral health be part of the work that they're already doing, part of those weekly home visits, without it being too burdensome? And so we want to work together to discuss that so that it's something that's feasible and can be sustained into the future. We also are sharing resources. As Katrina mentioned, there's lots of good oral health resources out there, and we want to get them into the hands of home visitors. We're also looking to explore how oral health may be integrated into home visiting curricula in the state. Now I'm going to switch gears a little bit to our outreach to pregnant women. We have in the state a Healthy Teeth, Healthy Kids oral health literacy campaign, which is a plain language campaign, and we are expanding that to focus on oral health during pregnancy for Latinas. And so we're doing that. It's getting ready to start in the beginning of October, an 8-week radio campaign on a very popular Spanish language station in Maryland. We'll have a radio advertisement all about oral health during pregnancy, where there will be some interviews aired. There'll be Pandora, Facebook, and YouTube ads all about oral health care during pregnancy. And we're doing this in partnership actually with our state oral health coalition, the Maryland Dental Action Coalition. And I'm just going to show you, we have a new brochure as part of this campaign that is about oral health care during pregnancy. This is the front of it there. I'm going to flip to the inside. These are the campaign's 3 key messages: that dental care during pregnancy is important, both for the woman and for the future infant, that it's safe, and that in Maryland, if women have Medicaid, it is a covered service. And then there's some very basic tips to take care of the mouth there. Okay, I think that's it. If you have any questions or would like to hear more, please feel free to reach out to either myself or Ilise. Thank you.
Thank you so much, Ilise and Katy, for sharing all of your great work in Maryland. Our next speaker is JoAnn Wells. She is the HRSA Perinatal and Infant Oral Health Quality Improvement Expansion Grant Consultant in the Dental Health Program at the Virginia Department of Health, Division of Prevention Health Promotion. She'll be sharing this quality improvement program and also touching on how Virginia has expanded Medicaid dental coverage during pregnancy. JoAnn?
Thank you. Hello, everyone. My name is JoAnn Wells, and I am the Perinatal and Infant Oral Health Consultant for the Virginia Department of Health. Virginia's oral health program has been in existence since 1921, and following national trends in recent years, programs have transitioned away from clinical and restorative care toward broad population-based preventive care. The Perinatal and Infant Oral Health Program at VDH involves work with internal and external partners to improve oral health for pregnant women and infants. This is important because women and their healthcare providers, including dentists, need to know more about the safety of dental treatment during pregnancy and about the growing evidence that the lack of oral health care during pregnancy can have a negative outcome for both mothers and their newborns. It's essential that we increase current and future interprofessional oral health workforce capacity and establish the necessary partnerships to advance integration of oral health into clinical practices through education. Why is oral health for pregnant women and infants becoming a focus for the Virginia Department of Health? This is a critical time for us to address perinatal oral health because in 2012, as you've already heard, there was the release of the Oral Health Care During Pregnancy, a national consensus statement, and HRSA launched the Perinatal and Infant Oral Health Quality Improvement, or the POQI initiative, as a pilot grant program. In 2013, HRSA expanded the POQI grant funding, and in 2015, the Virginia Oral Health Coalition began providing interprofessional trainings with medical and dental providers. And in 2015, as part of Governor McAuliffe's A Healthy Virginia program, the Smiles for Children dental program began to provide coverage for dental services to pregnant women. The Smiles for Children benefit went into effect on March 1st, 2015, and this coverage was extended to pregnant women aged 21 and over who are enrolled in Medicaid and Famous Moms. A comprehensive list of services, including diagnostic, preventive, restorative, and operative procedures, is covered. Important to note that the dental benefit extends through the month of the 60th day after the baby's birth. So, with federal guidance, funding for perinatal and infant oral health initiatives, statewide collaborative interests through the State Oral Health Coalition, and comprehensive Medicaid dental benefits for pregnant women, VDH set out to expand on activities to improve oral health for pregnant women and infants. Before discussing our current activities, I would like to first tell you about Virginia's Title V MCH history that continues to help shape the future of perinatal and infant oral health in Virginia. Previously, the dental health program was primarily Title V funded, but changes in priorities for Title V funding were noted and funds were redirected. At the time, federal funding for oral health became available, and VDH was awarded several grants, including the State Oral Health Collaborative Systems Grant, Targeted Oral Health Surveillance System Grant, and the Oral Health Workforce Grant, and the state-based Oral Disease Prevention Grant, and state general funds were also allocated for preventive service programs. A key feature of the State Oral Health Collaborative Systems Grant project was the development and implementation of the Bright Smiles for Babies, the BSB program, and it incorporated oral health assessments, fluoride varnish application for high-risk infants and young children, and parental education. The Targeted Oral Health Surveillance Systems Grant also established a program to improve access to oral health services for children with special health care needs. Although MCH National Performance Measure 13 was not selected in Virginia, Title V funds continue to support oral health programs regarding children with special health care needs, and early childhood health remains a priority in Virginia. The dental health program continues to collaborate with Title V programs on projects and opportunities to expand upon current oral health initiatives and explore new initiatives that have emerged. We continue to partner with Title V staff on multiple projects, including Text for Baby, home visiting, resource mothers, and oral health for individuals with special health care needs. A recent collaboration with the Text for Baby program will allow the dental health program to send customized oral health messages with Virginia-based resources to pregnant and postpartum women across the Commonwealth. The ability to customize messages will enable us to direct women to local numbers and websites for information and services instead of national resources. Messages are sent in both English and Spanish and are timed to be sent at different intervals during pregnancy through the baby's first birthday. VDH will also develop and disseminate a special oral health message to be sent in February, which is Dental Health Month. In addition to working with the Dental Health Program on messaging, the Virginia Maternal and Child Health Coordinator recently provided training on Text for Baby to our POCI grant colleagues in Maine. Oral health is an integral part of preventive health care for pregnant women and their newborns. Many health professionals are aware of the importance of oral health, but often do not address it as part of their wellness plan during preconception and prenatal stages for women of childbearing age, during pregnancy, or during the baby's first year. To address this, since 2005, VDH has implemented the Bright Smiles for Babies fluoride varnish program to reduce the risk of childhood caries, increase awareness of the importance of integrated care for medical and early child providers, educate parents on the importance of the primary dentition, daily oral hygiene, and the dental home, and improve access to preventive dental services in non-dental settings. This program utilizes hand-on and didactic training on oral health and hygiene and the application of fluoride varnish for healthcare providers, including pediatricians, physician's assistants, registered nurses, and licensed practical nurses. Additionally, in-depth online training for nurses on implementing the Bright Smiles for Babies program in the local health department setting has been developed, and it's available on the Commonwealth Train portal. The Virginia Department of Health leadership has encouraged implementation of this program statewide. VDH staff provide oral health services in WIC and Well Child clinics. Services begin with a risk assessment for infants and young children who have yet to establish a dental home to help anticipate and prevent dental disease before it starts. Services are provided using the knee-to-knee position as seen in the pictures. Fluoride varnish application is a billable service for dental and medical providers. In addition to screening and the application of fluoride varnish, oral health education and dental home referrals are key components of this program. In fiscal year 16 alone, 6,692 fluoride varnish applications were provided by the dental health program staff in non-dental settings such as WIC, Head Start, and Care Connections for Children's Clinics. Additionally, the number of medical providers trained to apply fluoride varnish continues to increase substantially. Virginia's individuals with special health care needs oral health program began as part of the Bright Smiles for Babies program, but with the focus on oral health for children with special health care needs. This program is now a distinct program for all ages of individuals with special health care needs and provides education to a variety of stakeholders and dental professionals statewide. The goal is to provide better access to care by increasing awareness of how to treat individuals with special health care needs and therefore increasing provider comfort levels in this area. Since 2011, 642 dental professionals have attended the Virginia Department of Health oral health courses related to individuals with special health care needs and early childhood. 1,743 health professionals, lay professionals, and other individuals have received oral health education regarding individuals with special health care needs, pregnancy and early childhood, and over 2,000 individuals with special health care needs have received preventive oral health services at Care Connection for Children, medical specialty clinics, and other disability-related resource events. It is essential that we increase both current and future interprofessional oral health workforce capacity to integrate oral health into clinical practices. New perinatal oral health initiatives aim to educate maternal clients regarding oral health during pregnancy and about the importance of the age 1 dental visit for babies, and to encourage providers to refer women for professional dental care to follow up on their care and to encourage establishing a dental home by age 1. After a successful pilot period of 3 years, the Virginia General Assembly passed a bill in 2012 to revise the practice of dental hygiene for those dental hygienists employed by the Virginia Department of Health to practice under remote supervision, and allowed the Virginia Department of Health to have a concentrated focus on preventive programs. The Virginia Department of Health Dental Health Program currently staffs remote supervision dental hygienists in 13 of the 35 health districts. Although pregnant women are occasionally seen in the Bright Smiles for Babies program in our WIC clinics, there has not been a concerted focus on this population. As such, with our POCI grant, we will expand the remote supervision dental hygienist roles and strengthen services to pregnant women, providing care coordination of services, data collection for WIC, enrolled pregnant women, and the infant population. This model will establish the effectiveness of having public health staff involved in an active role in care coordination in addition to clinical services. The remote supervision dental hygienist activities in WIC involve screening and referrals, implementation of the Bright Smiles for Babies, and the individuals with special health care needs programs to include provider trainings and the promotion of oral health resources. VDH needed to obtain baseline data for the POCI grant to assess the oral health status of pregnant women enrolled in WIC. That was the catalyst for the 2016 basic screening survey of pregnant women. to collect specific oral health indices and information, the basic screening survey criteria from the Association of State and Territorial Dental Directors was utilized. The ASTDD also provided epi-technical assistance. The dental health program is conducting oral health screenings and surveys of approximately 600 pregnant women ages 18 and older enrolled in the WIC program. The statewide sample includes 20 WIC clinics throughout the Commonwealth with a target of at least 30 women per site. The survey will reflect statewide representation but not produce regional or district level estimates. The screening is being conducted by the Virginia Department of Health dental hygienist, uses national guidelines, and takes approximately 5 minutes. Completion of the survey is anticipated in the fall, and results will be used for policy and program planning to address disparities in access to dental care and oral health outcomes for pregnant women. The basic screening survey is composed of 2 components, a questionnaire and a clinical open mouth assessment. The questionnaire is to be completed by the participants, is based on other national data sets, including the Pregnancy Risk Assessment Monitoring System, PRAMS, and the Behavioral Risk Factor Surveillance System, BRFSS. The clinical survey is performed by dental hygienists and assesses caries, periodontal disease, and the urgency of care. All participating women receive free oral health or oral hygiene supplies for themselves and their new infant, and information on the Medicaid dental benefit for pregnant women, referral information, and follow-up from dental staff. It's imperative that the Virginia Department of Health establish baseline data regarding oral health status and access improved services and document our progress that impacts this population. This slide contains oral health resources for Virginia. The Virginia Oral Health Coalition website has a useful integration toolkit for health professionals that would be helpful to anyone considering medical and dental integration projects. And this is my contact information. Feel free to contact me regarding any information that is contained in this webinar. Thank you for the opportunity to share Virginia's perinatal and infant oral health activities with you today.
Thank you so much, JoAnn. I'd like to turn it over briefly to my colleague Emily Eckert at AMCHP, who's going to provide a quick overview of additional quality improvement efforts underway in the states with support from MCHB. Emily?
Thanks, Catherine. As Catherine just mentioned, we just wanted to briefly share some additional information with you all on the POCI project that was mentioned in the previous presentations. The Perinatal and Infant Oral Health Quality Improvement Project uses a quality improvement approach for grantees to identify successful strategies and practices that can be implemented to improve oral health outcomes. This project is one of the major initiatives around oral health funded through MCHB's Division of Child, Adolescent, and Family Health that provides grants to 16 state grantees working to reduce the prevalence of oral disease in both pregnant women and infants through improved access to quality oral health care. The grantees involved come from varying agencies such as universities, departments of health, Medicaid, and healthcare organizations, and are working on their own unique strategies to improve oral health among pregnant women and infants. Though each grantee may not directly associate with their Title V program, their work will ultimately contribute to efforts around NPM 13A and 13B as they make progress on the oral health status of women and infants in their respective states. Also involved are the national network partners led by the Children's Dental Health Project, who support the work of the grantees by acting as the convening entity for grantees to come together, share, and learn. The national network works to foster collaborative learning and collect information on the successes, challenges, innovations, and insights from each grantee throughout their project period. If anyone is looking for additional information about the POCI project, You can visit the link below, or you can feel free to reach out to a member of the AMCHP staff. Thanks, Catherine.
Thanks, Emily. And now turning to our final joint presentation, we'll hear about health plan efforts to educate pregnant women about the importance of dental care and connect them to services. I'm so pleased to introduce Dr. Timothy Custer, who is Dental Director for the Dental Network of America, and Angela Hastings, who is Director of Exchange Product Ops for the Retail Exchange Affected Market at Healthcare Service Corporation and Blue Cross Blue Shield of Texas.
Okay. Thank you very much. Hello, everyone. Good afternoon. This is Dr. Custer. And as my slide indicates here, I'm also joined today by Angela Hastings, who is the Director of Healthcare Management with Blue Cross Blue Shield of Texas. Our presentation today, Dental Wellness in Pregnancy, Before, During, and After, will focus on steps being taken in the private sector by an insurance carrier to accomplish three things. Number one, to assist expectant mothers to better understand and manage their pregnancy. This being accomplished through our voluntary prenatal program, Special Beginnings. Number two, to increase the awareness to the importance of dental health. And number three, to increase utilization of their dental benefits. Numbers 2 and 3 accomplished through our dental wellness program, Blue Care Dental Connection, which will be discussed at a later point in the presentation. But as our title indicates, before, during, and after, these efforts are a process. It's an educational process that begins before pregnancy and continues after childbirth. So it's a packaging of initiatives that we do unique to each of our members. So during our presentation, you'll see or hear a reference to a variety of companies. So to avoid any confusion, let me explain more precisely who Angela and I work for. Angela works for, obviously, Blue Cross Blue Shield of Texas. I work for Dental Network of America. Both companies are part of Healthcare Service Corporation, or HCSC. And HCSC is a non-investor-owned mutual insurance company that operates through its Blue Cross and Blue Shield divisions in 5 states, in Illinois, Texas, New Mexico, Oklahoma, and Montana, and also through several subsidiaries, one of which is Dearborn National. So Dental Network of America is the dental portion of Dearborn National and is the administrator for all dental products for Healthcare Service Corporation. So as I make a reference to our efforts and initiatives in this presentation, our efforts and initiatives apply to all Healthcare Service Corporation members. So with that said, I'd like to begin our presentation with Angela providing an overview of our voluntary prenatal program, Special Beginnings.
Hi, and thank you, Dr. Custer. This is Angela Hastings. As Dr. Custer stated, I am Director of Case Management for our Exchange Operations program, and that is essentially our retail market segment with Blue Cross and Blue Shield. The Special Beginnings program, as he stated, is a comprehensive maternity program designed to assist our pregnant members in better understanding and managing their pregnancy. The Special Beginnings program integrates high-risk pregnancy identification and the case management program and is managed by dedicated registered nurses and board-certified case managers with backgrounds in labor and delivery, postpartum, pediatrics, high-risk OB, and NICU. The Special Beginnings program is designed to provide access to appropriate prenatal care for our members. It also provides ongoing coordination of care by the case managers with expertise in obstetric case management. It also identifies and promotes utilization of facilities appropriate for high-risk deliveries and neonatal emergencies. It helps to improve clinical outcomes and promote prenatal and assessment of risk for members in order to reduce the likelihood of preterm delivery. It helps to reduce the cost associated with preterm and low birth weight infants. It also promotes well baby care. And we provide outreach to the Hispanic community by utilizing Spanish-speaking nurses and translating educational literature in Spanish. We also provide fathering tips and screen our participants for depression at 6 weeks postpartum. Our program provides these services prenatal and postnatal health education and guidance from pregnancy to 6 weeks after delivery. And it is also offered in all the planned states within HCSC, which are Texas, Illinois, Oklahoma, New Mexico, and Montana. Some of the key points that the registered nurse case managers emphasize with this population are that good dental care is very important in pregnancy and may reduce the risk of preterm labor. They also strongly encourage our members to seek regular dental care, including dental cleanings early in pregnancy. In addition to good daily dental hygiene, brushing, and flossing, also professional cleanings and oral exams are important. Pregnancy increases the risk of dental and periodontal disease. So good dental hygiene can prevent other medical conditions as well and complications of pregnancy. So once enrolled in our case management program for Special Beginnings, our members receive an in-depth pregnancy questionnaire that helps us identify whether they have any risk factors that might adversely affect their pregnancy. And the results of that questionnaire actually determines the level of outreach that our members will be provided with from the case managers. They also receive a very nice and helpful book which covers a multitude of common pregnancy and infant care topics. It's called The Simple Guide to Having a Baby, what you need to know, how to stay healthy during pregnancy, how to care for your baby, how to handle labor pain. And there's also a section included in the book that talks about seeing your dentist for checkups and why you should get treated for things like gum disease and infections during pregnancy. I'd also like to just give the disclaimer that the Special Beginnings program is designed with the goal to assist healthcare providers and members in better coordinating care and improving health outcomes. The program is not a substitute for the independent medical judgment of a healthcare provider. Healthcare providers are instructed to use their own best medical judgment based upon all available information and the condition of the patient in determining a course of treatment. Regardless of any benefit determination, the final decision regarding any treatment or service is between the patient and the healthcare provider. So the Special Beginnings program is completely voluntary and a benefit of Blue Cross and Blue Shield of Illinois, New Mexico, Texas, Montana, and Oklahoma. A member's benefit will not be affected if she decides not to participate or if she withdraws from the program after she has enrolled. Thank you. I'll turn it over now to Dr. Custer.
Okay, thanks, Angela. Our wellness program, Blue Cross Dental Connection, is based on the premise that oral health impacts one's overall health. And in doing so, it addresses a wide scope of health issues. Everything from dental-only issues, such as adult gum disease, to tooth decay in kids, to medical dental complications, as it pertains to women's health, such as prenatal, obviously, diabetes, and heart disease. So it's a program designed to educate our members in a targeted fashion, doing so by either web education, integration of data, and internal resources, or an outreach, just overall general outreach. And it's a program designed to engage the member. So it really has one goal in mind, that is to educate the member so they will change the behavior. Do something now that they weren't doing, let's say, 12 months before. So our dental wellness model has 5 components to it, intended to educate the member and incentivize the member. The 5 components are web education, data mining and outreach, integration, and really 2 levels of incentives designed to encourage the use of their dental benefits. One of which is enhanced benefits, which I'll discuss a little later, and also the second is just discounts on dental products, such as Procter & Gamble products, that being Crest toothpaste, and their other associated products with that. So the member having either access to one or more of these features really allows them to really educate themselves or to be educated, whatever best fits their needs and whatever best fits their style. Our job with this program is to put the information out there. Our job is to identify the member, educate the member, and then follow through with the member on an ongoing basis over and over again. So our web education is our wellness website, Dental Wellness Center, as you can see here. And like other websites out there, they're all pretty similar, obviously. They're all very interactive, it's very self-serving, and really it mirrors many of the web tools already found on the medical side, such as a cost advisor. It has an Ask a feature, Ask a Dentist feature, the risk assessments, a library of articles, information, everything from A to Z. So for the user of this, for the member, prenatal or not, it's a very comprehensive site and very user-friendly. And for those members, those patients that like getting their information, firsthand and doing their research, this really, this website here really serves as one-stop shopping for those level of members. But we also chose to enhance the visibility of oral health to members enrolled in Special Beginnings by modifying the landing page to their program, as you can see here. And we did so by including a teaser question about dental hygiene, which is in that maroon box down below. And we did so because, just as health and exercise and diet are important to the expectant mother, so is oral health. It's just as critical to both the mother and the child. But it gets, as you heard in previous presentations, and just my own personal opinion, it gets a lot less attention than it should. So by linking to this resource page and within that box, the member has the option to either select our dental wellness website, which you have just seen, to give them information, or linking to the page you see on the right here, where the member can have more access and more information about oral care for both the expectant mother as well as her baby. Okay. Our education is targeted. Our program mines data. It mines medical data and it mines dental data, and it tells us who's at risk at different time intervals. Either it's a monthly basis or a semi-annual basis or an annual basis. It tells us who is at risk for dental-only issues, and it tells us who is at risk for certain health conditions that may be complicated by dental, such as pregnancy. And our range for doing this is all ages in our program, everything from birth to 100, for example. And our targets are based on certain milestones, certain life events along the way. So, for example, our targets could be something as basic as missed cleanings, missed dental cleanings, or just your first cavity, or something a little more personal, a little more complicated, such as being pregnant and having your first child. So if you think about it, if we were targeting a member in this process, let's just say we're targeting Mrs. Smith, our program would reach out to her before her pregnancy if she missed the cleaning or she had some recent treatment for gum disease. And that outreach there would be with a certain message. Our program would reach out to her during her pregnancy with a different message, obviously. Our program would reach out to her after her childbirth with a different message, and our program would reach out to her for her baby's first birthday, again with a different message. So our logic here is that these are all, important life events that warrant education and require some action to be taken. And our logic here is that we will do it over and over and over again, because at some point the message, based on the life event, based on how important it is to the individual, something will stick. And again, if we take our outreach very seriously with this program, and in fact, in 2015, our targeted outreach contacted almost 600,000 healthcare service corporation members between dental and medical dental messaging. So it's a very comprehensive program, and we take it very, very seriously. So the question often asked is whether improving oral health can truly impact a pregnancy, either by reducing complications or reducing medical costs. I mean, it really is no question that a pregnancy complicates one's oral health, as you've seen recently in the previous presentations, and also as supported by the American Dental Association or the American Academy of Periodontology. With all the bodily changes that go on during pregnancy, there's an obvious effect on the mouth. But the question really is, does the arrow go the other way? The question is whether poor oral health complicates a pregnancy by either preterm birth and low birth weight baby or low birth weight. And to be honest, the debate is still open on this. Over the past number of years, there's been many studies, many articles on this topic, and some argue a very strong association between periodontal health and preterm birth and low birth weight. And others argue there's no association at all. And they're all from reputable sources. So really at this time, at least in my opinion, the jury really is still out with something definitive on this topic. But regardless of which argument, holds more water, the consensus is that maintaining oral health is a critical component for the expectant mother as well as ultimately for the child. And that's the basis of our program, and that's the basis of all our efforts in this program. So our program identifies expectant mothers and educates them about the importance of dental care. And what you see here is a snapshot of our 2016 mailing that went out for prenatal. That was released in June of this year, 2016. But our education, doesn't stop at childbirth. As you can see here, lingering dental problems with the new mother can also be a source of cavity-causing bacteria being sent along to the newborn. And really with all the obligations that come with having a newborn, I would guess personally that this topic you see here is pretty far down the list for a new mom to remember. There's plenty of other things to be worried about aside from, her oral health. So basically because of that, our program takes the initiative, identifies the new mothers, and educates them about the importance of dental care and how best to avoid having these cavity-causing germs spread to their newborn. And again, what you see here is a snapshot of our 2016 mailing that went out in June to the new mothers we identified. And of course, knowing that the rule of thumb, first checkup by the first birthday is often overlooked by many people. We remind new parents with the birthday card you see here that it's time for the baby's first checkup. So the birthday card really does two things. It sends a birthday wish, but also reminds the parents if our data shows there's not been a checkup yet in our system, this will go out and remind the parents it's time for their baby's first checkup. First checkup by the first birthday as a rule of thumb. But of course, efforts are one thing and outcomes are another. And what you see here is a snapshot of our 2014 outreach mailings, which represents members that were in need of education, members that were in need of changing their behavior, and as a result, members who received the mailing. So in each category you see here, just for example, I use these three categories, these members had no cleaning or no checkup for the 12 months prior to our mailing. So for periodontal, 12 months following the mailing, 7% of members followed through after our outreach and received the cleaning. So if you think about it, let's say we reference Mrs. Smith again, that we talked about earlier. If Mrs. Smith was in the 7% group of members, this would have been a great start, for her getting her oral health under control before becoming pregnant, before planning a family. I guess it's an excellent start just having this kind of an outreach. For prenatal, 25% of members followed through and received a dental checkup. So again, in reference to Mrs. Smith, if she was in this group, having a checkup would have identified any potential oral health issues caused by her pregnancy. And then lastly, for new mothers, 21% followed through and received a dental checkup. So again, for Mrs. Smith, one more time, having a checkup at this stage of her career, of her life, this would have avoided having oral health issues that may have contributed to transferring any kind of cavity-causing bacteria to her newborn. So, it's all about different life stages and different messaging. Our program also coordinates a communications calendar using social media to complement each of our wellness mailings, and oftentimes in concert with various monthly themes, whether it's a Diabetes Awareness Month or a Healthy Heart Month or Children's Mental Health Month. And what you see here is a recent posting that went out, I believe it was last month, for prenatal. So again, it's all about repetition. We have our mailings going out, and we follow through in various capacities to re-engage the member and remind the member of the message over and over and over again. In this case here with the posting about prenatal. Okay. So our program accommodates all types of mediums because obviously in our membership base, everyone's different. Some prefer paper, so we use our hard copy mailers. Some members prefer technology, so we use our emails and our social media and our wellness website, Dental Wellness Center. But some people, their preference, their hot button, their motivator could be a person-to-person contact, or it could be just pure financial, dollars and cents. So to accommodate them, we integrate internal resources as another means to educate the member and change the behavior. What you see here are three examples of this integration, all being utilized today, some involving prenatal, and the ones that are not involving prenatal are planned to be started up next year, 2017. The examples are sharing data with the medical personnel to close dental gaps in care, using customer service message campaigns as a means to re-engage the members on an ongoing basis, and offering enhanced benefits to reduce, as a means to reduce any level of financial barriers to care. So at this time, our process of sharing real-time data with our medical staff at this time is limited to diabetics and heart patients only, those that are enrolled in our medical management programs. But for the purpose of an example, I want to show how it works, because we'll be doing this next year for prenatal. The way the program works is we share information like you see here, which allows for a dialogue about dental gaps in care between the member and the nurse clinician. And the information we have, you can see making a reference to an 18-month gap in care for cleanings or perio work. This is embedded in their health summary on a monthly basis. And will continue every month, month after month, which then allows for the dialogue between the member and the nurse about the importance of a cleaning. And this will happen until the member goes in for a cleaning and then drops off our list. So really, until the member gets a cleaning, every time the nurse contacts the member and opens this chart, dental is a part of their clinical indicator, which then allows for some dialogue and education about the need for a dental cleaning. So we envision, again, the same type process to be initiated in 2017 for members enrolled in Special Beginnings, where the process will be identifying dental gaps in care, like you see here, sharing it with the nurse clinician, and using it as another means to educate the expectant mother and how better to manage their pregnancy by improving their oral health. Okay, and a snapshot just of how this dialogue is working up to this point. This is a snapshot from our second quarter in 2016 for our diabetic and heart patients. So on average, roughly 5.5% of members follow through with a dental cleaning after having this information embedded in their health summary, and we assume having some dialogue with the nurse clinician, which really is very, very good. So as a means to, to further influence members already contacted through, let's say, mailers or emails or social media previously, involving medical personnel is really proven to be a very, very effective means to get the member to do additional treatment. Because again, certain people, this is what the motivator that was necessary, a person-to-person contact. Okay, and customer service campaigns, medical or dental, can be customized for any message, any audience. And really it serves as an effective means to re-engage the member, reinforce a message following a previous contact, whether that contact was previous mailing or, as I just mentioned, dialogue with the nurse. And what you see here are outcomes from a campaign we ran and finished up in May of this year. And again, this particular campaign didn't involve prenatal, but that is planned for 2017 as well. But what this does show is how effective a customer service campaign can be. So what we have here with this campaign is targeted our mailings from last year that went out to diabetic or heart patients, but also missed a cleaning for the previous 12 months. And the campaign involved all 5 Blue Cross plans with Healthcare Service Corporation, but the numbers you see here, just for the purpose of this presentation, involve just Illinois, Blue Cross of Illinois. So with the campaign, our target audience was 1,270 members. Over the course of 12 months, 265 called into customer service, of which 257 agreed to hear the message. And of those, 86 then turned around and received a cleaning or some level of periodontal treatment after the customer service contact. So again, at 33%, it's a very, very good outcome. And again, as our plans are to use a similar campaign next year to reinforce both the prenatal mailings as well as members enrolled in Special Beginnings. And to some members, as I mentioned before, it's all about finances. It's all about the dollars and cents, so we offer enhanced options as an incentive designed to encourage the use of their benefits by reducing financial barriers to care. So for example, with enhanced benefits, we offer richer benefits or extra benefits based on the combination of the service performed and the member's health condition. So for example, for cardiovascular disease, the members would have richer benefits, 100% benefit for scaling services, as well as for periodontal maintenance services. For diabetes, it would be the same matching for scaling and periodontal maintenance. And for pregnancy, it would be the richer benefits for scaling, richer benefits for periodontal maintenance, but also extra cleanings, and extra checkups during the term of their pregnancy. And what you see here, just an example of one company's experience offering enhanced benefits in Illinois, where you can see, over the course of a year, the employees use the benefits of extra cleanings, for perioral maintenance, as well as scaling services performed, which might not have been performed at all if it wasn't for the incentives in place. So that was very, for the purpose of encouraging members and giving some incentive. It's good to see that the services are being rendered as they present here on the slide. Okay. And lastly, in 2015, we launched a project to deliver dental kits to a select number of members enrolled in the Special Beginnings program, about 350 kits. And what it included was a package of a power brush, rinse, paste, and floss. So, as opposed to, using our mailers and our emails and our websites as an educator, this time we use products as a means to reinforce the message that oral health is very important to both the mother and the newborn. And this was very, very well received, as we received testimonials for probably 12 months afterwards from the members who received this. And with that, I will turn the slides back over to Angela.
Thank you, Dr. Custer, for that very comprehensive view of our programs within HCSC. I will conclude with a couple of scenarios that are based on, information that we have received from our membership and questions that the case managers that manage that population come across as they are managing these members. And it relates more to the dental coverage itself. So for the first scenario, the question would be, what would happen if a woman is enrolled in a qualified health plan through the marketplace and becomes pregnant but does not have a standalone dental plan? And so what we noted was, as part of our case management program for Special Beginnings, we would screen the member through asking a series of questions, and that was the questionnaire that I alluded to earlier, which has some targeted questions related to oral health. And we would have a discussion telephonically and also send email correspondence, educational correspondence. We would have a conversation with the member regarding the importance of practicing good oral hygiene and maintaining good oral health, and then advising that poor dental hygiene may result in and places them at higher risk for going into preterm labor. We would also provide instruction on how to obtain additional information on the subject through other reputable organizations, to include the American Dental Association and also Colgate. They also have some really good information for women regarding oral care during pregnancy. If the member were to inform us that they did not have dental coverage or inquired about whether or not there was dental coverage available for them on or off of the exchange, we would then make sure that we were able to get them over to someone in customer services or sales to talk about, to give them more detailed information about the standalone dental plans that are available when, that are available for purchase. Per our sales division, we do offer standalone dental plans to our members in all the plan states, to include offerings for Illinois. All adults have the option of enrolling or not enrolling in adult dental plan offerings when an on or off exchange medical plan is also purchased during open enrollment. However, if the adult purchases off exchange coverage for a child, they must also purchase pediatric dental coverage, even if it's a newborn, or provide the insurer reasonable assurances that they have pediatric dental coverage elsewhere. For the second scenario, or the second question, which would be, and we got that quite frequent, and it would not only be Illinois, but the other plan states, would Blue Cross and Blue Shield reach out to promote a standalone dental plan, and can these be purchased outside of open enrollment? If they can't purchase a plan, what happens? So enrollment in the dental plans on the marketplace are limited to the open enrollment period, or when the individual has a qualifying life event. And some examples of those are marriage, divorce, the birth of a child, court order, etc. So individuals may inquire directly to dental plans available outside of the marketplace to determine if such plans allow enrollment in coverage outside of their open enrollment period without requiring a qualifying event. Our care management programs will also seek to provide any available community resources for dental services that may be available to members in their service areas, but the member has to follow up with the resources to inquire about the requested services for themselves. And some examples of those services are low-cost or free dental services that may be provided in the different plan states. And we have an electronic resource base that separates the resources by states and counties that tell us whether there are any dental services, for example, available for our membership in that particular state or that county. And Dr. Custer did talk about dental coverage in some of his slides, and this particular slide just alludes to some of the resources, which include Blue Care Dental, which is available for individuals and families. And our members also have the option of going onto our websites and participating in a program called Blue 365, which is a wellness program that offers, among other resources, dental resources for personal care. One of them being the dental solutions that you see there. That is a discount program with a network of dentists that our members can elect to be a part of. And it's really small there, but you see the benefits that they can join along with their families. There's no waiting period. They don't have to worry about the forms or the qualifying events and that kind of thing. It's a monthly fee, and they can join and for however long they would like, and discontinue if they wanted to discontinue. But that's another option for them if they've missed the open enrollment period and do not have dental benefits or have not elected dental coverage, because for some women it may not have been planned that they are now pregnant, but they did not elect the dental coverage. So this may be an alternative or a solution that they could use in the interim, and then hopefully in the next open enrollment period they might elect to get the dental coverage. Okay, and thank you for allowing us the opportunity to speak with you regarding pregnancy and oral health. Again, my name is Angela Hastings, and my email address is angela_hastings@bcbstx.com. Dr. Custer, did you have anything else in closing?
No, that should be it. Just passing it back to Catherine, I guess, to coordinate any kind of Q&A.
Thank you both so much for that comprehensive presentation, and we are excited now to invite our audience to submit questions. We still have our full panel of speakers with us for a few more minutes if they want to come off mute, and you can see instructions on your screen for how to ask a question if you're joining us via the phone, and you can also still type questions into the Q&A box, and my colleague Emily Eckert from AMCHP is going to help coordinate the Q&A session. Emily?
Yeah, thanks, Catherine. Before we jump into questions, I just wanted to make sure to extend a thank you to Catherine and all of the staff at NIHCM that have been supporting this project. I also wanted to thank my colleague at AMCHP, Stacey Collins, the Associate Director for Health Reform Implementation, for her guidance on this project. Again, a big thank you to the Maternal and Child Health Bureau for funding our work, and a huge thank you to all of the speakers for providing their expertise today. So I can see quite a few questions have flooded in throughout the presentation on the chat feature. I just wanted to address one question that came in through the registrations that I think is particularly interesting. We heard a lot in the presentations about integrating home visitors and other sort of community health workers into this outreach work. And there was a question from the registrations asking, kind of touching on how the public health workforce is changing and how home visitors and other folks are taking on these greater roles, and even if we think about the new concept of dental therapists and kind of expanding licensures for certain dental services, how do you all see policy impacting this evolving structure of public health? And any presenter can answer that question.
Well, this is Angela. I think for the retail markets as it relates to us, I think it's probably a kind of a wait and see kind of thing, kind of depending on how things go in this next election as to, where the exchange or the retail market will be going and how this particular segment of the population will be managed. Because right now we know that this particular population is very Medicaid-like, but we don't have the resources that may be available to members or to people that actually have Medicaid coverage, and so sometimes it presents a challenge to get them engaged, first of all, and then to fully educate them on how to best maximize their insurance benefits, to talk about having insurance, period, and then educating them on how to utilize it and maximize the benefit itself. But I think essentially we're going to kind of have to wait and see how things go as to how things will transpire as it relates to the exchange or the retail market.
Great, thank you, Angela. Any other comments for that question? Okay, we had another question come in on the chat feature about how to best work with WIC offices and encourage those partners to get on board with dental screenings. Any advice for that?
Go ahead.
Hi. Go ahead.
Does Virginia want to go, or was that Virginia?
Yeah, that was, this is JoAnn, but Ilise can go. That's
no,
fine.
Go ahead, JoAnn, because you did a whole thing on it, and then we can chime in.
Yeah.
So go for it.
I wanted to just say a few words about the other question, because I've been with VDH for many years, and I've seen the transition, that's kind of moved away from clinical, care toward the population, the broad population-based preventive care. And one of the ways that we have transitioned into WIC and how we've worked very closely with a lot of our partners here is through our WIC program here at the State Health Department. And they have supported us with working in the WIC clinics. When we moved to the remote supervision dental hygiene model, it just made sense because we had 2 full-time dental hygienists initially back in 2005 or 6 that actually, started out working in WIC clinics. So we looked at that model, and now we've expanded it. But, all of our partners here have been just, very good to work with as far as oral health programs and local health departments, including, all the public health nurses, where we're reaching out with them now with the well child clinics to provide, the Bright Smiles for Babies program with, children as they come through for immunizations. I don't know. I hope that answered it.
So this is Ilise from Maryland. Just building on that, we've probably almost 17 years ago really garnered support from our state WIC office, and that really was the impetus to kind of get our local agencies on board. When approaching local agencies individually, our programs had some challenges because they kept coming back to the state WIC director, really trying to figure out if this is something that was in their scope, what should they do about it. Obviously, you are all very aware that WIC runs under some really tight federal regulations. So there was always some of that concern. Once we were able to really partner from a state perspective, our local agencies and the coordinators really were able to, fulfill and try to figure out how to best meet their clients' needs, whether that was doing dental screenings in their clinics. Some of them have cordoned off a separate room. Some of them have been able to provide education, depending on what that WIC service agency looks like. Education in terms of training and education for all of WIC staff was something that we were able to do from an early time. And just really, building on the fact that a risk factor for receiving WIC services is poor oral health. So that's one thing that was really able to kind of move WIC out of the, oh, there's a risk for, poor oral health. Well, here's something we can actually do about it as well.
Great, thank you all. A number of questions have been coming in for Dr. Custer and Angela. I'm just going to combine a couple of them quickly here. So number one, how does Blue Cross Blue Shield identify their pregnant members? And how exactly did you determine the percentage of effectiveness of the mailings to your members?
Okay, we have access to both medical and dental data, so I can't speak specifically as to what is identified on the medical side, but I do know they mine the medical data to identify claims that have come in that would make a reference to the individual being pregnant. And when that information is identified, then that person is matched up against, is there also dental coverage? And then if there is, then that person goes into our queue as a member to identify for our outreach mailings, as well as everything else that with the pregnancy. So I can't specifically reference what is identified on the medical side, but our analytics folks on both medical and dental know what to look for, whether it's pharmacy or various examinations coming in to identify that feature.
Yes, and I would agree with that claims are the primary source that our analytics teams use to identify this population. We also, however, are working with one of our medical directors who has a background in OB to try and identify some of these members a little earlier. And she's looking at using some of the other CPT codes that come in for specific tests, like quad test and what were some of the others? Some of the, I think the maternal fetal monitoring is one of the other ones. Just some very specific testing that's done at specific stages in the pregnancy that identify these members, and then we would have our staff outreach to the providers to confirm and to determine that they're seeing these members, and then we would in turn outreach to the members who needed outreach to inform them about the programs, and then, again, it's voluntary, so if they wanted to join, they could. We're most interested in identifying our high-risk population and those that we can assist in really maximizing their benefit and identifying early to get involved in some of these programs that will help with their oral hygiene and oral health.
I guess one more question regarding the effectiveness of the mailings. Basically, it depends on which category of members are being approached. Again, for the periodontal, our determinant to determine whether they're at risk would either be two categories. One, if they've had no cleanings, routine cleanings in the past 12 months, or they've had a recent treatment involving gum disease treatment, scalings or surgery, which means they're also at risk. So for the sake of that one slide I had, the 7% focused on those members that had no previous cleanings routine in the past 12 months. Following the mailing, our claim data showed that those routine cleanings codes showed up in their claim history, which then basically gave us the assumption that the members followed through with some treatment, at least a routine cleaning, following the mailing. The prenatal and new mothers really are two things. One, we mail to them as long as they're identified as a new mother or pregnant. So the whole population gets a mailing from us, whether they're in good health, bad health, whatever it may be, because our mindset is that they should know this information regardless of their condition. What we do is then find a subset of that mailing, and we look for how many of these members, prenatal, new mothers, have had no checkups, no annual checkups for the previous 12 months. And then following the mailing going out, how many followed through with an annual checkup using the examination codes in the claim history. So what you see here on that slide represents those members, which is a subset of the whole mailing that went out, that represents those members that followed through after the mailing for annual or for a dental checkup.
Thank you so much, and thank you to all of our speakers. Unfortunately, we're running over time today, but I do want to thank our excellent panel of speakers who took time from their busy schedules to be with us today and share this great information. We do encourage all of our participants to take a moment to share feedback from this event by completing a brief survey. We've had a lot of questions about the slides and recordings, and all of the slides are currently available on our website, and a recording will be made available and sent out to everyone that registered for the event today. And just one final also thank you to our partner AMCHP and to MCHB for helping to convene and sponsor this event today. So thank you all.